we want to get to questions, and overwhelmingly, we had so many people who wrote in and said the new numbers are in.
Right.
And we've heard a whole bunch of people twist and bend and rotate these numbers around for whatever, and people would like to hear from you. What are your thoughts? And of course, I'm referring to the CDC numbers that were announced last Thursday, that here in the United States, from this every 2-year study, 1 in 68 children.
1 in 68 children, 1 in 42 boys.
Yeah.
Which is even more scary, I think. You know, I have so many different thoughts about this. Of course, I'm not sure. I didn't think we'd be... I mean, I remember you and I talking about this. I think I said, well, I guess maybe it could be up to 1 in 60-ish or something like that. But, you know, that seems kind of high to me, to be honest with you. And I've been the one saying all along, it's still too low, it's still too low.
Yeah.
But so now I feel like, okay... Well, you know, I don't know much about this population. So I don't know, you know, I know that it was different states.
Yeah.
I know that it was an average, and there are still higher rates in certain states like New Jersey. New Jersey's been at the top for a long, long time.
Yeah.
We should really be looking into why that is.
Absolutely.
Although I do know that also, just on a side note, that New Jersey is one of the toughest states when it comes to vaccines. You know, you can be thrown in jail if you don't vaccinate your child in New Jersey.
I did not know that.
Yes.
Interesting.
So there's certain things like that 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 are curious, the big ratio difference. You know, and then of course there's the fact that, I think it was something, I don't have the study in front of me, but over 7% of these children had normal or higher than normal intelligence.
Yeah.
Which is awesome, I think. I believe that one.
Yeah.
And I don't care what people say about this, because people will say, oh, that means that the diagnostic criteria has changed, or
we've heard that a lot.
You know, that they're now looking at higher, low, you know, different type of child. It's not. The other day someone said that to me. It was actually an interview that we were doing, and they said something like, well, how much of this has to do with better diagnosis? And I said, you know, it's like, this has been said to me forever. And I have to remind everyone, like, when I started in this field back in the 70s, we're talking 1 in 15,000 children. What was yesterday or a few days ago, I was going through some documents. Oh yeah. I was looking for some books on anxiety for my son who's in school and needs that topic right now. And I came across some old books that I was studying when I was a student, you know, in psychology at UCLA, and I found that looking at those made me realize that I had trained on the DSM-3 originally. And then, the DSM-4, 4R, you know, and now the 5. So I've been through multiple changes of the DSM, of the diagnostic manual. And I really have to say that if, you know, it hasn't gotten easier to get a diagnosis of autism. It has just changed the way that you look at it. But I went back and looked at it, I just had the DSM-3 at home, and I was looking at it, and I was like, that's probably easier to give that diagnosis, because we just know more now. We just know a lot more than we did back then. And so it was a much broader categories that you would fit the kids into. Now it's much more specific, you know. So it's actually, in my mind, harder to give the diagnosis now than it was back then. So that it wouldn't make sense that it has anything to do with the diagnostic. And the truth is, we all know it's increased. There's no question it's increased. I mean, I heard on the news, I think yesterday, this is the most rapidly increasing disorder in the United States. There's nothing that's I think, what was this, another 20%? What was the growth again?
30%.
30%
over the
again,
last 2 years.
And then 60% over the last 4 years. And if you just keep looking, it's you know, I can't even go back to the days when I started. That's just a huge, huge increase. Yeah. So we know that it's real. But what I've always said is that the children that we see, that it is a different form. It is different. No question that in the past, 30 years ago, it was more severe. There's no question. I used to have children that were, one out of every 4 or 5 kids back then was severely self-injurious, you know. And you haven't even seen that. I haven't seen that level of self-injury for years.
It's interesting that you should bring that up, because we had a question that came in from a viewer last week, a dad who said, how come we don't see everybody talking about the more severe kids right now?
Yeah.
He's got an older child, and he said, it's frustrating to me that I feel like I turn on things, and including our program. He was being critical of our program, saying, I feel like you guys focus on the kids that aren't in that severe category. Why aren't you talking about? And that really touched my heart in a way, because we say that we cover autism from a 360-degree perspective, but we of course encourage people to get the proper care. And what we find is that a lot of times when people do, it seems like their children aren't on the severe end. I know that doesn't explain, because not all kids make that amount of progress, but maybe you could address that for this parent about, there are still kids who are severe, but is it just me? They tend to be the kids who are older who didn't get as much care.
No. There's some young children who are severe.
And are getting the proper treatment still?
Oh, yeah. There are some children who are incredibly severe at a young age. Not as many, very few.
Okay.
See, so let me go back and address this a little bit. So going back to, back in the 70s, the majority of kids were in some way or another what we would classify severe.
Okay.
I mean, when I say self-injury, I don't know that anyone has ever seen the stuff I've seen. Okay. I mean, I've seen little children bite off their own fingers completely. We had children at Camarillo State Hospital who had bitten off their shoulder. I mean, that's a different level of severity, right? Some of the kids would bang their head. We talk about head bangers.
Yeah.
Right now we have head bangers, kids who will hit their head on the wall and then look and see if someone saw it. That's not self-injury.
Okay.
That's attention-seeking behavior.
Right.
Self-injury is when you hit your head in the wall without anybody being there, and you do it so much that you have a protrusion here that looks, that's huge. Like, that's real self-injury. So there's no question that the form of autism has changed. Now, the question is why? The whole concept of self-injury is pretty interesting, so you have to think about that for a minute. If we consider it to be just a behavior, right, just like anything else that we do, that's, let's say, aggression towards others, aggression to yourself, whatever it is. There are theories on self-injury where people say that it has something to do with not being able to feel your sensation is not enough, and so therefore you are provoking some level of sensation in yourself, which I suppose is possible because we don't know enough about self-stimulatory behaviors to begin with. We don't know, we're just beginning to really learn more about the sensory aspects of what our kids go through, and certainly there are children who are overloaded with sensory, no question. That one I would sign my name to, there's no question, even though there's not much research on it, but I know that's the case. And so how do we know? Maybe there are also kids who are very low on the sensory. In other words, they have a huge high threshold and they don't feel things a lot, and therefore they're trying to produce some sensation, right? So they're passing their own threshold. That could be a reason for it.
Yeah.
How that would have something to do with environmental change, I don't know. Maybe, it has some, biologically, biochemically, it could be something that plays with our senses in our environment, in our food, I don't know. But the other side of it, Shannon, is that if we do self-injurious behavior out of frustration, which is the strong belief, right? So then things have gotten a little bit better. So in other words, when I look back at those children who were incredibly severe, they were in state institutions, okay? And they were receiving like a thousandth of the level of care that our kids get today.
Right.
So that could explain some of the drop in that we have learned in the field of behavior analysis, the field of special care, special education, has learned how to understand these children better and how to understand the function of their behaviors in a way that we make life a little bit calmer for them. You know, of course, if you are hitting yourself because, or if you're aggressing or whatever it might be because you're in pain, and someone helps alleviate the pain, obviously you're going to do that behavior less. You're not in pain as much, right? So I think we've definitely learned to take care of our kids better than we used to back then. I mean, but in the 70s, there was still a lot of experimentation. There was a lot of intervention that involved punishment.
Yeah.
Pretty severe punishment. So, and even it wasn't until like maybe 15 years ago that schools even stopped doing timeout and restraint and all this sort of stuff. So things have become much more civilized, let's put it that way. And that might be showing a positive response. Now, having said that, we do certainly, I have children who are maybe, I don't know, 6, 5, trying to think of my youngest kids, who are very severe. Okay, and so these are the things that I see when I say severe. Severe is a silly word. It just doesn't mean anything. But what I mean is that they're the hardest to manage for their parents, for anyone else. They're just the hardest. Why are they so hard? It's because they function at a different speed. If I had to kind of summarize the things that keep them, like, you know, put them in some group, they definitely function at a different speed. They're all super, super fast.
Okay.
So they're not regular speed. So they're not really catching a lot of what goes on around them. They're very sensory kids, so they either have touch aversion or they need, like, you know, they need to be held on, and it's very sensory stuff. Visual sensory, a lot of visual sensory going on with the kids where they're looking at things. So they have severe, you know, what now we now call sensory dysregulation.
Okay.
And often they have biochemical issues. So, for instance, they might be in pain. They have a lot of GI issues. Most of my severe kids have GI issues. And the combination of having pain and having being severely disturbed by your environment's sensory input and your brain functioning at a different speed makes it virtually impossible for them to learn. Makes it almost impossible for them to learn. So we get, you know, like, I'll just give you examples. Like, so I have children where they have, you know, 10 times a day diarrhea.
Yeah.
Okay. So you know this child is in pain.
Yeah.
And he has pretty much no nutrition or nutrients going to his brain anyway. Extreme sensory. So everything kind of sounds startle him, lights bother him. Oh my gosh, like the visual input, I don't even know what his visual input is because he's so restricted. He can't match two items, and it's not his intelligence, it's simply because he doesn't see things the way we do. I mean, we had to modify even the most basic lessons of matching, you know, putting two objects that are identical, because we know his auditory input is very affected. We know his visual input is very affected. We know he's got a ton of sensory issues. All he wants to do all day long is run back and forth and go ee and all this sort of stuff. And guess what? Like, you know, what we could do, we had to make all of his stimuli textural so that he could actually, just like a blind person, feel them and hear them. So they had to have some sound too.
Crinkle.
That would help him identify what's what. And that was the only way it would work with him, as well as, of course, you know, we gave him his own sort of comfort areas. Everywhere he goes, you know, so we've taught him how to use sunglasses, you know, how you put headphones on to avoid sound, go sit in a beanbag and put your music on to calm yourself however often you need it. He's been on a very restricted diet. I mean, but yet, you know, and I've worked with him for a few years now, and so yet as he approaches 8, 9, and 10 or whatever it is, it's still, he's so far behind in terms of, because we can't get through and teach him these things, because how do we learn? We learn through our senses.
Right.
So, very long answer, but that's kind of where I see it with my very severely affected children.
Okay.
I think it's those three components, you know, their sensory and their activity level, and some form of biochemical, whether it's pain related or just inflammation, or, you know, and it's tough. How can you pay attention? How can you learn? How can you look at something if you have all of those issues?
Right.
It's impossible.
But does it seem like that some of those kids now are being helped by some of the different, in a more extreme way, that between the, like, for some kids it's not getting there yet, but for other kids
it's kind of like you and I were just talking about the diets.
Yes.
Right. It's similar in that sense that if you have a slight reaction, then you can kind of go on a diet and make some mistakes.
Right.
And you'll still be fine.
Right.
Okay. If you have a mediocre reaction, then yeah, you can go on a diet but you really shouldn't make mistakes, but maybe a tiny, like we were talking about VSL.
Yeah.
You know, and if you take VSL3 and it's dairy, it has slight amounts of dairy or something, will it affect you or not? It really has to do with your reaction, right? And then there's other level of reaction or allergic reaction, and that would be when you're like our kids, right? Where you absolutely have to be very strict.
Right.
And that you cannot, if you have a tiny amount of dairy, it'll throw you off for a week.
Yeah.
Right?
Yeah.
So for those kids, you have to be much better in the diet, much more correct, much more precise. And that's the same thing with our severe kids.
Yeah.
If you can't be flexible. You have to be perfect. You should see some of my therapists. I'm amazed at them, I swear. Like they wear aprons now, some of the therapists at Carta, and they have, you know, an iPad in one for the child to communicate, a token chart hanging from their apron. Here they'll have like a reinforcer pack of things, and they're like non-stop, you know, like they have 12 hands, and you have to be on the child. It's almost like you have to be two therapists to a child.
They're octopi. That's what they are.
They're octopi.
And they are kings and queens of multitasking. I've seen them, and I will never understand how well they do that. But
and that's only and that's just the ABA portion.
Yeah.
So you know that at home the families are struggling because they have to be like absolutely strictly on some form of diet, absolutely strictly get this child his medications, injections, whatever it is he needs, you know?
Yeah.
So when you bring all that together, our kid, and actually, I want to say this for the parent that was listening, this is very important, and I hope that you'll be listening to this. The children who are very, very severe, as they age, get better. Okay. They do actually calm down at a certain age, as long as you have, like maybe past puberty, but as long as you have good care, they're much, much, much easier to teach when they're 17, 16 than they are when they're 5.
Okay. And I think by that point, a lot of times people have thought, oh, the ship sailed, we can't do anything, but don't
That's
give up.
not true.
Okay.
Some of my kids that make the most progress that I'm the most proud of right now are 21.
Okay.
22. I love some of my kids. Oh my gosh, they're so... Oh, I love that population. I just do. I love the older kids. Make me crazy. They're so amazing. They're so sweet and kind and lovely, you know.
Wonderful. We should take a break. I've taken you far off course,
sure,
but we should take... No, my bad. But important stuff, especially on this day, to acknowledge all the different aspects of this spectrum that we're talking about.
Absolutely.
So I'm glad that we talked about it. But we have to take a break, and then we're going to be back with a very special surprise for Dr. Granpeesheh. Stick with us. Welcome back to Autism Live and to Ask Dr. Doreen. We have a very special treat. We've been talking about doing this for a while. We want to make it possible for parents to be able to speak directly to us. Even with our live feature, sometimes there's a delay. And we know how reinforcing Dr. Granpeesheh finds it to be able to talk with parents. I will say this before we do anything. Even we're about to Skype with a parent. And even in that format, I want to let everybody know that Dr. Granpeesheh still can't give child-specific advice. That even in this format, we can't do that. that. No one on the show can do that in this format. But we have a parent.
It's exciting for us.
It's very exciting. We have a parent who's going to be joining us via Skype, and she has a question for you.
Oh, that's awesome.
And we will tell you in a little while how more of you can participate in this new feature that we're going to be doing on the show. But first of all, joining us via Skype is a wonderful autism mom. And so are you there?
Yes, Shannon, I'm here.
Oh. So thrilled to have you with us. I have to start by asking for your permission for us to be videotaping you.
Absolutely.
Okay.
You have all my permission. Thank you.
Well, thank you. And did you want to introduce? You don't have to introduce yourself, but would you like to introduce yourself?
Sure. My name is Marcella, and I have a beautiful child. She's going to be about 7 years old next in a couple of weeks, and she's in the autism spectrum. And thanks goodness that she's making good progress, thanks to all your support.
Well, we're so thrilled that you are here with us for this inaugural Skype with a Parent with Dr. Granpeesheh. And you had a question for Dr. Granpeesheh.
Yes, Shannon, and this is a very, the question that I would love to know more, because it's kind of like where we're standing for a little while now and struggling a little bit. Well, my daughter, let me tell you a little bit about her first. She is high functioning. She's in the autism spectrum, and she has hyperlexia, meaning that she knows all the words that you could even imagine. And she has a good vocabulary. She is very good at mastering lessons. We use the skills for a while. So any lesson gets mastered in a couple of hours sometimes on the table. Wow. So when the therapist speaks to her, she's do intraverbals. She can ask WH questions, answer WH questions. But when we try to generalize it to the peers or family members, like even to ask, can you go ahead and ask Papi, how was your day today? And then she has to be prompted, and nothing, we're stuck there for a while. She has a very good eye contact, and she's very intelligent. But the way we were trying to do this, so just to tell you where exactly she's at, is, for example, if she's playing with a dolly, or if she's eating something that she likes, and we ask her a question like, say, you want to go play with us outside, or why don't you ask your friend, hey, you want to play with me? And she completely doesn't do it, ignore it. So we hold the toy or hold the whatever she's entertained with, and then she knows, oh, okay, so you're playing the game, I have to answer to you, and then she does answer. But nothing comes voluntarily, it's not spontaneous. Everything has to be prompted. And we know she has the language, she's just that little, I don't know what happens. So that will be my question. How can we improve that, and what technique or what can we do from now?
To start this, though, I have one quick question. Before your child was diagnosed with autism, had you ever heard of the term intraverbal before?
No.
Okay, so let's start there. And I love that you know what that is now, but maybe, Dr. Granpeesheh, if you could start by explaining to the audience at home what an intraverbal is.
Sure. Well, I think you're actually going a little bit beyond the intraverbals.
Okay.
And you want spontaneous intraverbals. So intraverbals are when you are, these are, let's not get into technical terms here, but basically operants as a whole are the class of verbal behavior that we teach. So manding, for instance, is requesting items. Tacting would be labeling. Intraverbals are responding to something in the environment or something that isn't necessarily present. So that would be, for instance, what was mommy wearing today? Blue. Or what color is the sky? Blue. Right. Whatever it is. But it isn't prompted by some direct object or something in your environment. So that's sort of a very watered down definition of what intraverbals are. But what I think this mom is asking about is, Marcella's talking about, is that she wants her child to be a little bit more, first of all, spontaneous is the ultimate goal, but I don't think we're even there yet. I think what you're saying is that you want her to respond or to use her language faster. Because right now it seems like you actually have to hold the object for a while until she figures that she's not going to get the object unless she vocalizes, right? Okay.
Right.
So you have two things that you can do which are pretty simple. First of all, she's hyperlexic, so you can use word card cues to prompt pretty much anything. and you can flash them even. With our kid, in other words, you can, if she needs a prompt with anything, whether she does or not, in this case I don't know, but if she needs a prompt with anything, you can write it down, what her answer should be. And then you can just literally show it to her initially and then just flash it. And then after a while you can just flash a blank card and it'll be a reminder. And after a while you'll just touch the card and it'll be a reminder, and you fade that out. But in her case, I think if she's figured out the fact that a vocalization is required in order to get an object or get the next stage of wherever she's going, but she waits, then what you have to do is you have to make her understand that it's her response speed. So you have to make her understand that she needs to respond faster. So let's say you'll say, what do you want? And you want her to say, you know, I want to go outside and play. And you'll not allow the door or whatever. You won't allow her to go or get an object until she says it, and this drags on. So time the duration that it takes. This is called latency, Marcel. So you will time the period of time that it takes before her response. That's the latency to the response. And now you have a time frame, let's say 15 seconds, average. So you'll take maybe 10 segments and you'll average them. And now your point is to decrease that. And the normal time frame of response will vary based on what the situation is, what the distress. So you just have to look at other kids, for instance, and you'll get the normal time frame. And now you're just trying to shape it. So the way that you shape it is that she loses all opportunity to that thing unless she does it within a slightly shorter time frame every day. So it's like, let's say we're starting at 15 seconds, that's what you allow. And then after that, you won't allow 15 anymore to be 14. And once she's successful within 14, then 13, 12, just gradually decrease it. Make sure that she's successful, well, you can't make sure. Don't worry if she loses it the first few days. She's so smart. And the way that you can do it is that you can increase it by visual prompting, but reduce the time frame. Getting rid of visual prompts are easier. Does that make sense?
Yes, that makes a lot of sense, because that gives me an idea. Okay, we're here. Even if it takes me a minute, then I will at least, short it to 30 seconds at one point and hopefully reduce the amount of waiting.
And actually, I have to tell you, 30 seconds is probably also for a response. And this is actually really important. It's probably too long, because kids, when they interact with her, will lose interest within probably 5 or 10 seconds. So you have to make it much faster.
Yeah, and I have a follow-up question, if
Sure.
I could. Shannon, thank you.
Absolutely.
So, for example, my daughter has a one-on-one aide at school, and she's in a typical classroom, and she's kind of small than other children, so everybody loves Camilla, and they want to go with her and say, hi, Camilla. She's like the little one in the classroom, and it's just unbelievable the amount of exposure that she has to this, hi, Camilla, how are you? And she says hi, and she shakes hands, and she does high five and all that. But if somebody comes to her, because, if I ask her, Camila, what did you see in the zoo? She'll tell me, I saw this, this, and that, and I like this, or whatever. But if a friend comes with a little tiny voice and, not with a prompting voice that, mom or the therapist will have, she doesn't respond. And then I just, tell her, Camilla, go tell her what you see. But, that voice, I think it's the tone of voice, and not just don't know how to generalize that. So she can also answer those two little other voices that she knows that they're not holding a reward for her to say a good answer.
Yeah, you really seriously should go to school and become a BCBA. You get these things. It's funny because with the prevalence rates going up so much, I've started to, unfortunately, but it has now hit our own family at CARD, right? And I've diagnosed quite a few now, of the children of my own supervisors. And I think it's actually worse when you are a supervisor, because it's just so natural to you to communicate with children in a certain way. Behavior analysis teaches you to communicate with people in a certain way, especially with children. I find myself doing that all the time. And other adults and other children don't do all the things we do, and we're not even aware of it. So what you're doing is many things, actually. It's not just the tone of voice. You are probably getting in front of her so that she has an easier time scanning and finding you. You're probably getting down to her level. You're probably a little bit louder. You probably speak more clearly and slower. You probably are conditioned to be the person that gives the reinforcers all the time, and she's learned because of all these things to tune out everything else and really focus on you. So and that's great, but so the problem you're having is generalization, and you will need to become a worse therapist and you will also benefit from using a child as a therapist. So bring a child with whom you can, so that you can tell the child how to do this and how to get. So I used to use my daughter Charlie when she was little all the way for many years. I used to use one of my kids, actually all of my kids, for play dates because I could teach them. I had taught them this is how you get his attention. This is when you give the reward. This is what you need to do for him to look at you. Wait, give him the chance to focus on you, that sort of stuff. So if you can find a cousin or somebody like that who can help with that a little bit, that'll help. Mm-hmm. But more importantly, you need to just start fading your own, you need to become more and more normal in terms of communication. And the generalization goes from you to the normal you, the therapist you, to the normal you, to other adults, to a therapist type child, to one other normal child, to a group of kids. So that's sort of the whole process, the group of kids being the hardest.
Yeah.
Perfect. That makes so much sense.
Yeah,
That's exactly what I didn't know. So she's just this little bit to,
Are you doing a lot of hours with her outside of school also?
We are, whatever we can, because she comes from school at 4, and then we're doing Epsom salt at night, so, and the whole other interventions, vitamins and things like that, with the also dietary changes. But she goes to bed about 7, so we only have 3 hours.
Right.
To do whatever we can.
Is she, what I need you said you used to use skills. One of the things that happens, and I just want to caution you, I don't know that I should caution you because I don't want you to worry either, but I would feel bad if I didn't say this, is that when our kids are that smart, when they're very smart kids and they're hyperlexic and they learn that fast, we tend to think everything's fine and we're over the hump. And we kind of okay, wow, she went from very little language to look how well she is doing now.
Yeah.
How well she is doing now is not your goal. Your goal is normal development.
Yeah.
So don't stop the intensity until you reach normal development, because we get lazy with it. As our kids start to function, they don't have behaviors anymore, they're doing okay, academically they're very strong, that sort of thing, and then we stop paying attention to the things that are still there.
Right.
So I just don't, and I know it's tough when you're working and our kids are and your child's in school until 4 or whatever. That's tough, but if you can, make sure that the 15 hours a week in the afternoons are pretty intense. Make sure she gets hours on the weekends. Just try to pack it in, because she still has quite a bit of actual core lessons to learn. It's not just the generalization of these basic lessons, but core lessons of things that are much more advanced, like learning how other kids feel, learning how to communicate and converse with other kids, all that stuff.
Right. And just talking about how fast hyperlexic children learn, we're just blown away. It's just
It's
unbelievable.
amazing,
Yeah, but
Remember
and there
I said
also
that
gives us with a big problem, because we have skill lessons, and we're going all the way to the curricula, or picking up, and then we have a stock this big of master lessons on the table, which we have to generalize, and that's where we can't generalize it, because she's better at the table and learning and reading.
You're absolutely, and you're amazing considering that you kind of self-taught yourself all this stuff. I mean, you know
Thank
more than
you.
a lot of parents who actually have a supervisor working with them every day. But yeah, so it's a balancing thing. You have to generalize, maintain, introduce new stuff all the time. Yeah.
Okay. Thank you so much for being with
great
us and
talking
starting
to
this
you.
off exactly right. We so appreciate you. And good luck, and check back with us. We're going to take a short break, and then we're going to be back with more of Ask Dr. Doreen. Stick with us. Welcome back to Autism Live and to Ask Dr. Doreen. We just concluded our very first Skype call with a parent live during Ask Dr. Doreen, and I want to let all of you know that that's an option that you can participate in. If you're intimidated by the fact of having the camera, though, you don't have to have a camera on you. We can Skype with just sound. It's like a phone call. So if you'd like to do that, make sure that you email us, because it does take some foreplanning to be able to do that during the show if you'd like to ask a question live. A couple of questions that we've had come in this morning. Thank you, Dr. Doreen and Mrs. Shannon. I love it when people call me Mrs. Shannon. It's one of my favorite things.
Yeah.
I love you people. This is from India. My daughter is diagnosed with PDD NOS, 2.5 years old. I want to access skills, and I want to know payment options. Thank you. And I brought it up just to make sure that I was giving good information. If you go to skillsforautism.com and you want to click for parents, and it gives you choices of how you want to pay, because you can pay monthly or you can pay, there's a savings if you pay for the entire year all in one fell swoop. But then you continue on to pay for it, and your choices are Visa, MasterCard, Discover, and American Express.
Right, and I think you can also, I'm not sure now, I'm not involved with the marketing aspect of stuff, but I think if you get other families, if you're a group, you get a group discount as well.
Absolutely,
Yeah.
absolutely.
And you have a free period of, what, 2 weeks, I think?
There's a 14-day free
Right.
trial that you can do, and there's 2 different trials that you can do. There's one where you give the credit card information, and on the 15th day,
Yes.
if you don't cancel it, your card will be charged. But for that 14 days, you're not charged.
Right.
But you must cancel before the 15th day, or you're automatically charged for the next month. The other one is called Skills Light, and for that one, you don't have to give a credit card. You can look at it for 14 days, but you don't get to look at everything. You get to look at portions of skills that you can get a really good idea of what it is and how
I'm
it
glad
works.
we have that. That's great.
Yes, because some people are squeamish about
I don't
giving the
like
card.
to do that.
I don't like to either.
Whenever it's a matter, I have to be pretty sure before I put my card in.
Well, because I have no attention span, and so I know that day 15 is going to come, and whether I liked it or not, I'm going to get charged for it. So
Yeah.
I'm more comfortable with doing, but you don't get access to the whole thing, but still it's there, and you get access to enough that you get a really good idea if this is something that will be helpful to you, as I believe that it will be. So you can choose between those 2 trials. With Skills Light, at the end of 14 days, you're given a passcode, and at the end it doesn't work.
Right, and I think also now you get the
The builder is
VIP
included
builder.
in all of that, and yeah.
VIP builder and the CIFA, right?
Yes.
The card indirect functional assessment. What a name
That's
we
what
picked.
CIFA means.
And also, I would really recommend people do it right now, because we will, within the next few months, roll out Skills Book.
Okay.
And then you'll get Skills Book.
All right.
And that's
so
my favorite
that's a
part of
reason
the
to
whole
sign
thing.
up. All right. Remarkable. So that's how you can do that. Skillsforautism.com, and those are the payment options. It walks you through it very easily. I just looked at it to make sure it hadn't changed from when I did it, and it's very self-explanatory. So good luck with that, and write back and let us know how you're loving it.
Yeah, and let us know how things are going in India and what you're doing there for autism. I'm very, very interested in doing something in India.
Yes.
We have some staff out there, actually.
We've had more and more parents writing in from India. It makes me very excited. Okay, so the next question. My son is 7 years old, on the spectrum. I have a question about how to help me with a humming, almost like a growling with his mouth shut sensory issue. What can it be replaced with? We've been able to replace other OCD sensory need behaviors like jumping and excessive need to touch, things jumping on a trampoline and playing with his necklace or hair, which is much more socially acceptable, but we haven't been able to help him with the humming other than giving meaning or words to his humming. Thank you so much.
Well, I don't know, maybe some of my suggestions will help you. I don't know exactly what the humming's like, but here's some suggestions. First of all, make sure that you restrict this to a certain time of day, like a certain period of time. So for instance, you could easily shape down the time frame that he's allowed to hum to, I don't know, 4 10-minute segments during the day or something like that, or 4 15 minutes, or even more frequent and less duration. So shorter segments multiple times a day, but restrict them because you don't want him to be able to do this all day long. Second thing is you might want to replace it with something. You really have to find what the function of the humming is. Not that it has to sound like humming, but it has to just it has to satisfy whatever sensory he's getting out of humming. So there's a couple of things you might want to try. One is singing. Singing might give him the same level of sensory, and that would be very appropriate. If God willing that's the case, you put him in choir, get him involved with singing activities. And then the other thing I was thinking you might want to try is chewing gum, because once you're chewing gum, you're going to have a hard time humming. But so it'll be somewhat contradictory. It won't allow the two things to happen at the same time, which is good. But we don't know if it'll reduce the function, the reason for the behavior. So really, it's a matter of identifying why he's doing it, when he's doing it, trying to think, what does that do? Maybe it's just the sound that he enjoys. Maybe the sound of is what he enjoys. So maybe you want to teach him meditation. Or give him meditation music to listen to. Maybe that's what'll calm it down. It'll be easy to replace it once you know what function it serves.
Okay, I have a hummer. My child is a hummer. He loves to make noises, but loves to hum.
Do you know what humming? Is it very low volume?
Depends.
Does he hum melodies?
Now he does. When he was younger, it was just humming. And somebody had told me once that the vagus nerve is there, and that when you hum, sometimes for some people it stimulates the vagus nerve, which reduces anxiety. So I don't know.
Yeah, which is why meditation also works.
Right, what you were saying.
But that's very interesting. And I don't know, again, if you can shape it. We should probably think about it in terms of trying to shut out the environment in some ways. So perhaps if that's the function, give him other ways to do that.
Yeah, and it's been interesting over the years how the humming has changed with different people. I'm a bad therapist in that I don't always respond to it correctly, but one of the things that Peter Farrig used to do early on is that then when Jem would hum, Peter would hum something, and Jem's head would come up, and he would just be like, "What's happening?" Because he wasn't aware that he was humming. And then when Peter would start to hum with him, it became a thing where they connected, and he would immediately stop once he knew that he was doing it. And then later on, Peter would say to him, he would say, "Hey, buddy, would you hum in your head? Can you make that noise inside your head?" And ultimately, that's what Jem does at school. At home, I'm not a good therapist, and I don't curtail it very much. And just hearing you say, give it parameters about when to do it and when not to do it, I need to be better about that.
Only if it's disturbing or disruptive.
Well, he knows now he can't do it at school. It used to drive the other kids crazy.
At school, you can't hum. You're in a classroom. You have to be quiet and listen.
Taking a test. Yeah.
But at home, if you're working on a project or something and you're humming, I don't see anything wrong with that.
Yeah, and he did join the choir. In fact, so all the things that you were saying, and in fact, he just got invited to be in the honors choir for the all district thing.
See, that's awesome.
Because he's such a singer now.
And that's spectacular. But if it is an anxiety type reaction, we have to realize that people have a lot of different anxiety defense mechanisms, right? A lot of different. So humming would actually be a pretty adaptive one.
Yeah.
And this is like the comedians who are so amazing, and they do stand-up comedy, and you find out that they're actually the most shy people in the world. Like, they're so incredibly anxious about social stuff. So as long as you find if it is an anxiety function, find some other more adaptive thing for the child and let him do it.
There you go.
Wherever possible, I don't know, I like it when our kids hum and sing and stuff. I love it.
And Jem makes up songs now.
I think it's happiness, it's nice.
Yeah, it is actually a wonderful thing. I enjoyed hearing you talk about that. We are out of time, and I made you go over last week, and I don't want to do that again.
I'm sorry that we're out of time.
I know, but we get another shot at this next week, which I'm thrilled.
Yeah, I mean, and just because today is Autism Awareness Day, I'm not sure, and we should be thankful to Autism Speaks for making this a day that people think of autism, because to us, to all of our viewers and to us, autism is an everyday thing. It's not just today's thing. But, I just want to say, I guess autism has shaped my whole life, and I'm very grateful to all the opportunities that I've had with my kids and with the families, and I really, really love and thank all the families and all the kids for just being such a big part of my family. It's like, honestly, I have so many of my best friends are people who were family here, and I feel like I have such an extended family of children, because they write to me from college and email me and call me, and I'm tracking who's doing what. And I don't know if you know, I won't name, because a couple of them work for us. I didn't even know, as therapists.
I'm aware of one of them. That's pretty amazing.
Crazy that I found out about that. I was like, oh my gosh, that's amazing.
It is amazing.
So I just want to, send out blessings, I guess, to all families and our kids out there, and wish you all the best, and I guess tell you I'm honored to be part of this family. So.
Well, we are thrilled and grateful, and indeed lucky that you are a part of our family.
Thank you.
And we lean into you as the visionary that you are, and listen to your wise words.
Thank you
I'm
very
all
much.
weepy now, but we couldn't have picked someone better to follow.